Hello, everyone. Thank you very much for joining this webinar today about the tooth wear management. Today, we are going to discuss about the principles and guidelines for managing the tooth wear. So, everyone knows that the non-carious tooth surface loss (NCTSL) is considered as a current issue of concern. Its management is challenging, and the focus will be put on the different forms, locations, and causes. Emphasis is placed on the importance of a thorough examination and indexing to assess the severity of the tooth wear. And a systematic and integrated approach will lead to favorable and predictable prognosis of our treatment, and we should aim to provide a clear recommendation on the best treatment strategies and simplified guidelines to succeed tooth wear management, considering the patient's expectation, the aesthetic demands, as well as the risk profile. The patient should be fully informed, and the restoration of severe tooth wear should ideally be delayed as long as possible. The different treatment modalities will be discussed according to the localization and the severity of the tooth wear. The conservative, minimally invasive restoration also should be considered firstly and always. So let's get started. So as an introduction, non-carious tooth surface loss (NCTSL), also termed as a tooth wear, is a current issue of concern to dental practitioners regarding the diagnosis, identification of the etiological factors, prevention, and execution of an adequate treatment. It is a physiological process that occurs as a part of the aging process, causing an enamel loss of between 28 to 30 micrometer per year as proved by so many researchers. Although practitioners are often faced with the patient suffering from tooth surface loss, many challenges, when it compromises the tooth survival or when it is disproportionate to the presenting age. It is therefore referred to as being pathological. Indeed, various forms of tooth wear that commonly occurs are linked to the diet, paroxysm, parafunctional activities, and so on. This will lead to the loss of hard tissue because of the combination of mechanical and chemical process. The TSL forms do not include trauma or bacteria or developmental disorder. They are currently considered challenging when it comes to their management. So this is a flow chart of the tooth wear, where it shows us that the tooth wear can be categorized to physiological type or pathological type. So physiological type usually doesn't need any treatment, and it's only need a regular recall appointment. And of course, prevention is the first strategy with the monitoring and counseling with the specialist. How about the tooth wear, the pathological type? Actually, we need to identify the etiological factors and eliminate them, along with the evaluation of the risk factors and wear grading. Prevention also the first policy, and the monitoring and counseling with the specialist. And here we need to know that if the patient doesn't show any interest in treatment, or there are absence of symptoms or absence of dynamic tooth wear, so no need to interfere and no need to do any treatment, just we go with the regular control and observation. But if the patients with hypersensitivity or bulb exposure or dysfunction, and he wants to improve the function and the aesthetic, at that time we need to interfere and do the active management. So how about the tooth wear prevalence actually? The precise prevalence of tooth wear loss is hard to establish due to differences in assessment criteria complicated by coexisting factors. As expected, all studies showed an increase in the prevalence that goes with the age. Also, some study shows that an increase in the prevalence of severe tooth wear in the adult population from 3% at 20 years of age to 17% at 70 years of age. As for the children and adolescents, authors have also noticed that they don't exhibit severe attrition, but there are indications of wear mainly because of the dental erosion. So the classification, according to Grippo classification established in 1991, four types of surface tooth loss have been identified and distinguished by the different causes. So attrition. Attrition is defined as the wearing away of the tooth substance or restoration due to tooth-to-tooth contact. It can be mostly remarkable in patients with a vegetarian diet. It's generally associated with the parafunctional activity. The wear from attrition may be localized on the occlusal surfaces of the posterior teeth, the palatal surfaces of the maxillary anterior teeth, the labial surfaces of mandibular anterior teeth, and the incisal edges of anterior teeth. The affected surfaces are usually hard, smooth, and shiny. In certain cases, they may be sharp and jagged. The areas of attrition may be associated with a yellowish-brown discoloration if the wear has penetrated the enamel. Wear may also concern interproximal surfaces, leading to mesial drifting and broadening of proximal contact. This is a typical picture of a patient who's having attrition. Also, this one, we see that the yellow-brown discoloration, because the dentin has already been exposed. How about abrasion? Abrasion occurs when a dental substance wears away due to friction between the tooth surface and external agents other than an opposing tooth. Factors related to patients include abnormal process or habits. Toothbrushing has been incriminated as to be the main etiological factors in dental abrasion. This has been noted clinically while observing a coincidence of a smooth surface and or cervical abrasion as well as an extensive oral hygiene. This causes cervical abrasion where the severity depends on the brushing technique, time spent on the brushing as well as the force applied on brushing. Besides that, the abrasion of interdental areas may be the result of extensive use of interdental brushes or toothpicks. Nothing of incisal edges may be caused by pipe smoking or nuts and seed cracking, nail or thread biting, and hairpin biting, which are rarely seen today. So other external factors include, as we can see, material factors. They have been found to influence the prevalence of abrasion, such as the amount, pH, and abrasiveness of the toothpaste used for brushing or inserted within interdental brushes. Similarly, toothbrush stiffness and their bristle design and flexibility, mainly when they are associated with the aggressive brushing technique, and this one will explain this prevalence. As for the restoration, unglazed porcelain causes abrasion of the opposing natural teeth. Environmental factors also, they include exposure to dust and grit in some working places. As with attrition, the condition is rarely caused by single factors, with erosion being a common cofactor. This is a typical picture showing how's the abrasion, and we need to differentiate it from decay. Erosion. The term erosion refers to non-carious tooth surface loss caused by the chemical dissolution, not related to the acids produced by dental plaque. It may involve the entire dentition or be localized as a single solitary lesion. according to the characteristic pattern, two forms of erosion are to be considered. The first erosion pattern is characterized by evident concave depressions where enamel appears thin and translucent. These are commonly exhibited on the palatal and occlusal surfaces of the maxillary teeth, as well as the buccal and occlusal surface of the mandibular posterior teeth. This specific pattern is linked to the certain voluntarily or involuntarily medical conditions. The second erosion pattern is specified by scooped out depressions present on the labial surface of the maxillary anterior teeth, and this is mainly caused by dietary factors associated with the slimness food and acidic drinks such as fruit juices, carbonated or Coca-Cola drinks, or vinegar. Abfraction. Abfraction means that the pathological loss of the tooth structure resulting in a wedge-shaped lesion with a sharp line angles, which may be located completely beneath the marginal gingiva. Although these lesions have been recognized for years, their etiology has been debated. Numerous hypotheses were suggested to explain their exact cause. Practitioners widely accept that abfraction is related to atypical occlusal loading. It is a consequence of eccentric forces on the natural dentition, which were theoretically said to have been caused by a tooth fatigue, flexure, and deformation via biomechanical loading of the tooth structures. Cusp flexure due to lateral occlusal forces during mastication and parafunctions causes tensile stresses. This disrupts the chemical bonds presented by induced cracks in the enamel and dentin in the region of concentrated stress at the cervical region. While some authors, as we know, have shown evidence that supports this hypothesis, some people say that it's not solid, and they suggested that cervical lesions are properly accelerated when they are combined to erosion, abrasion, and attrition. Abrasion is the cervical region is usually distinguishable from abfraction by its smooth, rounded nature of the lesion, along with the minimal to extreme gingival recession with or without mesogingival defects. Gingival recession may also be seen with abfraction, but it's not a hallmark of these defects. This is a typical picture showing how the abfraction would be at the gum line. So, how about the non-caries tooth surface loss assessment? Numerous and many indices have been proposed to assist the clinician in recording the non-caries tooth surface loss. Tooth wear evaluation system is a modular clinical guidelines to optimize the diagnostic process, which is including the qualifying aspect and the quantifying aspect. The surfaces playing a role in the occlusion and articulation are graded for each sixteenth using a 5-point ordinal occlusal incisal grading scales. 0, it means there is no wear. 1 equals wear confined to the enamel. 2, wear with exposed dentin less than or equal to 1/3 of the crown height. 3 equals to wear more than 1/3 but less than 2/3 of crown height. 4 is the wear is equal or more than 2/3 of the crown height. Besides, because the palatal surface have a significant role in the articulation, the opposite sextant is also graded using a 3-point ordinal non-occlusal non-incisal grading scales. 0, there is no wear. 1, wear confined to enamel, and 2, wear with exposed dentin. Each score is then singly recorded but not summated. Tooth wear evaluating system enables the clinician to judge in advance the degree of the desired plan difficulty, and the appropriate decision considering the choice of the proper strategies of the treatment. In general, indices serve as an aid to assess the extent and severity of tooth wear and can serve as indicator of a need for treatment. Single indexing can be useful to quantifying the severity of the tooth wear, whereas several recalls are needed to successfully score the grade of tooth wear to determine or qualify whether it's a progressive, dynamic, or not. So how about the prevention strategies? Prevention of tooth surface loss is preferable to restoration. We need to remember that. To prevent tooth wear aggravation, etiological factors must be determined along with early recognition of signs and symptoms. Thus, prevention of further tooth wear ideally includes elimination of causative agent. This simple action is often impossible, though. Several researchers agree that wear progression can be reduced by patient education. This is why we need to emphasize on giving the patients oral health education, OHE, oral health instructions, OHI, and this is based on preventive advice tailored to the cause and the severity of the non-carious tooth surface loss. So it will focus on the dietary. Patients are required to confine acidic drinks to meal times in favor of neutral drinks like milk and water along the day. As for fruit juice consumptions, it's preferable to be consumed once a day. The use of wide-board drinking straws is highly recommended when consuming acidic beverage, which helps to reduce the tooth acid contact time. Adequate tooth brushing technique, brushing time, and frequency. It has been proved that dental tissues take 60 minutes to be re-established after contact to acid. Toothbrushing should not be performed soon after vomiting or after acidic drinks. How about fluoride addition? It has been proved to reduce the damage of acid drinks to teeth, whereas its application via mouth rinses, gels, is recommended to fight acid damage, requiring thus the use of 0.7% fluoride solution followed by some application of 0.4% fluoride. Other authors, as we know, reported that toothpaste containing potassium are also considered to be appropriate for the management of sensitive dentin. So when it comes to parafunctional activities, patients with some sort of GERD are advised to wear a protective occlusal stent. However, specific attention and rigorous hygiene instructions are recommended as acidic substances may accumulate within the splints, which may further accelerate the rate of tooth wear or exacerbate the rate of tooth wear. Reference to other medical specialties is recommended in case of voluntary vomiting and suspected gastroesophageal reflux. Patient stress control. It's key to tooth wear progression management. The previous method based on advice and lifestyle management are crucial to preserve the remaining tooth structures and to enhance the longevity of restorative treatment. Removing the etiological factors highly determines the treatment success, whereas failure can be early predicted if the factors could not be managed. So, clinical approach of wound dentition management. A thorough general and oral health history, as well as patient's emotional well-being and expectation, need to be considered. So for the clinical examination, an extraoral examination is necessary. It involves palpation, osculation of temporomandibular joint, the presence of muscle tenderness, as well as clicking or popping in TMJ must be checked. The opening trajectory is examined and any deviation on opening or closure must be noted. Another important feature to be marked is the enlargement of parotid gland, which is a typical characteristic of bulimic patients. Smile lip line, midline discrepancies, and facial vertical proportion should be also checked. Occlusal vertical dimension, which is very important parameter to be evaluated whenever you have a tooth wear management or case. It is critical to assess the loss of the occlusal vertical dimension before any restoration. The different techniques used are assessment of phonetics like sibilant sounds, the use of interocclusal distance, and the evaluation of soft tissue contours. The most commonly described method includes the freeway space evaluation, patient resting vertical dimension RVD, and the use of calipers or Wallace gauge. Some researchers stated that a compensation of OVD loss by tooth eruption, alveolar bone expansion, and muscle action could happen and took place. This is why if you have a patient who's having severe tooth wear and you expected that, if he has having severe tooth wear, that means that the OVD already collapsed. But when you do your own measurement and you find out that the OVD is still intact or sometimes is increased, you will be shocked. So what happened exactly? What happened exactly is that dental alveolar compensation. We need to take that into consideration. Dental alveolar compensation took place and it compensated the loss of OVD. And this kind of cases is actually the most challenging and more complicated to be handled. Whereas patients with OVD loss usually show overclosure and typically inverted lip profile. This is a case showing that the patient had tooth wear and has been accompanied by dental alveolar compensation. Intraoral examination, the quality of oral hygiene should be evaluated together with the basic periodontal assessment. Tooth vitality or tooth sensibility also need to be checked. A cautious approach is advocated with the patients exhibiting signs or symptoms of myofascial pain or disorder, as jaw relationship records may not be accurate. So the objective of the treatments, first, we need to provide a comfortably functioning TMJ system and adherence to the basic principles of occlusion announced by so many researchers. Restoration that will not violate the patient's neutral zone. Everyone knows that the neutral zone is the area where the forces that comes from the lip and the cheek neutralized by the force that comes from the tongue. So all the teeth should be, whenever we're doing the complete denture fabrication, we need to know that the teeth need to be arranged in this neutral zone. Simultaneous stable bilateral tooth contacts in maximum intercuspation position or occlusal maximum intercuspation. Centric relation or RCP, retrograde contact position, coinciding with the centric occlusion, which is tooth-to-tooth contact. A mutually protected occlusion, anterior guidance that guarantees immediate disocclusion of posterior teeth during eccentric movements. Canine guidance, indeed, we found out that the patients with the canine guidance have a higher success rate than those without it. Comfortable and asymptomatic temporomandibular joints and stomatognathtic musculature. This is showing you that the centric relation and centric occlusion, they are not in the same position. And the canine guidance, which always we prefer it. So criteria for treatment decision. Generally, when patients do not show any interest in the treatment and in the absence of symptoms, a preventive approach seems to be more efficient, mainly when the patient doesn't present a dynamic wear process. However, for some other cases, restorative treatment may be required. Nevertheless, prosthetic rehabilitation in such patients is risky and prone to problems because of the complex structures of the stomatognathic system. For those who show a high sensitivity and need to improve function, mastication, and aesthetic restorative procedures become highly beneficial. Some people stress the benefit of delaying restorative treatment to an older age to avoid recycling the restoration procedures in case of failure. According to tooth wear evaluation system classification, only preventive measures and monitoring should be advocated when grade 0 or 1 exists on the surface. 0, it means there is no wear. 1, it means the wear confined to the enamel that are involved in the occlusion articulation, and or grade 0, 1 to 0 or 1 in the non-occlusal, non-incisal surfaces. Similarly, restorative treatment is to be considered when grade 3 or 4 exists on the surfaces that are involved. Grade 3, it means that the tooth wear happened or took place in more between the one third and less than 2/3 of the height of the crown, and number 4 that the tooth wear happened or took place and occurred on the more than 2/3 of the height of the crown. And grade 2 on the non-occlusal, non-incisal surfaces, it means that's already within the dentin of the non-incisal or non-occlusal surfaces. So the material of choice. First, we have the adhesive technique. Currently, adhesive dentistry shows a considerable progress allowing advanced restoration techniques. Thus, many treatment options were proposed, such as direct, indirect composite resin restoration, cast adhesive alloy with a metal palatal veneers and onlays, and bonded ceramic restoration. We are using direct composite resin. We can use the freehand technique, the hemi-direct technique using a polyvinyl siloxane matrix guide, the hemi-direct using a thermoplastic vacuum form matrix guide, and the other one is the conventional fixed prosthodontics. It would still be a treatment or the treatment of choice for rehabilitating extremely worn teeth. However, such treatment is complex and is still considered to be invasive, not conservative. Indeed, splinting to compensate short primary poorly retentive abutments is contraindicated. Full coverage crown usually requires provisional restoration that should be seated for enough time to refine and validate the functionality of the occlusal design. So how about the adhesive technique or approach versus the conventional approach? Compared to conventional restorative techniques, which require removal of sound dental hard tissue, adhesive restoration are minimally invasive. They are described as a dynamic restorative concept. There is no need for tooth preparation to guarantee the retention, and the mechanical resistance will be offered using reliable materials where the resistance is increased by bonding. Besides, conventional full coverage crowns may lead to the loss of tooth vitality, where bulbal exposure is more likely to happen with the teeth affected by severe wear process. Thus, adhesive additive approach might be primarily considered when attempting to actively manage the tooth wear. So for the treatment modalities, in case of presence of pain, dysfunction, and pulp exposure, as well as aesthetic demand, restorative treatment becomes a necessity despite being technically complicated. So far, 4 restorative procedures have been described in terms of wear location, maxillary anterior, mandibular anterior, localized posterior, and generalized wear. Other factors include including residual tooth structures, geography of surface loss, available quantity of enamel, lack of interocclusal clearance, and aesthetic demands of patients must be taken into consideration. So this is a flow chart showing how we do the active tooth wear management. Tooth wear can be generalized first or localized. So if it's localized, in this case, we need to uh, use the adhesive additive restoration and make use of the or utilize the doll concept anterior localized tooth wear. But if it's the tooth wear is generalized, where most of the cases will be, we need to categorize it into three types. Category one, excessive tooth wear together with the loss in the OVD, occlusal vertical dimension. Here we can go for adhesive additive resin restoration, indirect ceramic, uh, or composite veneers, or we can go for the conventional restorative approach. And this one, actually, category one is straightforward case. Category two, excessive tooth wear without loss of the OVD, but with the limited space available for restorative material. And this is limited space. We will achieve it. We will gain it when we check the difference between the centric occlusion and the centric relation. So we can resort to indirect ceramic or composite veneers, full coverage crown restoration. Category 3, which is the most challenging and the most complicated category, it's where the excessive tooth wear without the loss in the OVD because the dental alveolar compensation took place and with insufficient space for restorative materials. So in this case, we need to go for surgical procedures like crown lengthening, or we can go for elective endo treatments, or sometimes we need to go for ortho treatments to do intrusion and extrusion for some teeth. And if it's all fail, we need to consider increasing the occlusal vertical dimension by using the occlusal splint. So active restorative management of localized tooth wear. In case of localized tooth wear, especially in the anterior maxillary region associated with the inadequate interocclusal space, we need to know that the interocclusal space, the ideal one should be between 2 to 4 mm in either centric relation or centric occlusion. The dial concept is adopted. It's very important concept. It's based on the cobalt chromium removable appliances in the maxillary anterior region retained by clasp on canines and premolars to increase the vertical dimension of 2 to 3 mm. It's based on the covering of the cingulum areas of the worn teeth, leading thus to posterior teeth disclusion and over eruption. This appliance is intraorally located until re-established interocclusal contact between posterior teeth over a period of 4 to 6 months according to Dow. Thus, a space is created between anterior maxillary teeth and mandibular dentition. Preparation of anterior teeth becomes thereby needless in favor of a non-invasive restoration. So this is how the doll appliance look like. Um, it's removable, and now they are doing it as a fixed using a composite or some temporary crowns on the anterior teeth. And the point is actually is to make disclusion or between the posterior teeth, so they will over erupt. Once they over erupt, that means that we will gain 2 to 3 mm of to increase the OVD, and then we will have enough space for the restorative materials as we see here in the picture. So limitations. In case of patients with malocclusion like class 3 or mandibular facial asymmetry, or with the patients showing limited eruptive potential, dental implants he's having in that area or anterior open bite is very limited to use. The dull appliance is not that effective. So due care has to be given also to the patient with a symptomatic TMJ or presenting periodontal disease if the teeth are mobile, or in post-orthodontic treatment, as well as among patients under oral or intravenous biphosphonate treatment, because these drugs will affect the bone structures. So this is a case also where there was a wear on the palatal surface of the anterior maxillary dentition, and there was a lack of interocclusal space. Then modified removable dowel appliances were used, and we can see from different view from the lateral that the space has been created palatally over approximately 2 months, and type 3 golden loyal palatal veneer cemented with the cement Banavia and checked for canine guidance, where we said that we always aim to have a canine guidance wherever it's possible. Posterior teeth in contact verified with the use of shimstock articulating foil, and this is how the palatal veneers look like 13 years after the cementation. And this is also another case for a patient who's having mild pathological wear affecting the upper anterior dentition due to a combination of bruxism, xerostomia, and gastric reflux. So diagnostic workup has been done. We noticed that the disclosure of the posterior units and immediate post-operative view following the placement of the resin composite before final polishing phase has been done. The placement of the resin composite has been aided with the use of silicone key formed like an index from the palatal surfaces of the diagnostic workup. And also we can see that the occlusal form established, even centric stops canine guided occlusion. And there was a separation of the posterior teeth immediately following the placement of the resin composite. And 3 months post operative picture, we can see that the re-establishment of the occlusal stops after a period of 12 weeks following the composite placement or resin placement. This is another picture, also shows an example of lower anterior tooth wear treated using a resin composite. And also here we have a mark wear on the tip of the canine, and we can see that the wear on the occlusal surfaces of the posterior teeth. Composite canine restoration were placed on the canine to provide posterior disclusion to prevent further wear. So we re-established the canine guidance again. Here we have a localized posterior tooth wear treated by the application of adhesive type 3 cast gold onlay, because the tooth wear is only localized on that molar. So how about the active restorative management of the generalized tooth wear? Category 1, as we say, excessive tooth wear together with the loss of OBD is the straightforward case. Category 2, excessive wear without loss of OBD, but with the limited space available between the teeth when we compare between the centric occlusion position and the centric relation position. Category 3, excessive wear without loss of OBD because the dental-liver compensation has taken place and with insufficient space for restorative materials. So category 1, they are the most straightforwardly managed. The required space for restorative material is already cleared through the tooth wear process. Thus, the increase in OVD or occlusal vertical dimension is expected without any occlusal reduction. There are two approaches to adopt: the adhesive additive and conventional restorative approach. So this is a case for a patient where we use the cemented overlays and provisional crowns at the lower left 5. And also we can see the presence of even occlusal contacts and centric occlusion. Provisional restoration were retained for 8 weeks, around 2 months, to enable assessment of the tolerance adaptability to the new occlusal prescription or dimension. Provisional restoration have been replaced with a definitive restoration, permanent restoration. Edential space has been restored with a tooth and mucously supported lower partial denture, removable one, and we can see the presence of canine guidance on the lateral excursive and protrusive mandibular movement. And here we have a case also of generalized tooth wear treated by the means of conventional porcelain fused to metal crown, BFM crowns. And there is a loss of OVD. Diagnostic wax-up is very important, mandatory to be done for every single tooth wear. case. Laboratory fabricated provisional restoration. Also, we can see personal PFM restoration or PFM crowns fabricated to copy the occlusal and aesthetic prescription derived from the placement of provisional restorations. Category 2, it's excessive wear without loss of OVD but with a limited space available. In such cases, an existing discrepancy may be noted between the centric occlusion and centric relation. The latter may provide space to accommodate restorative material. However, this space might not always be fully adequate, hence the need for an OVD increase needed. So the adaptability to the new occlusal vertical dimension and the mutually protective scheme are evaluated by using a splint, occlusal splint, continuously worn, except when eating during a month. So these patients are appropriate candidates for full coverage restoration. This is a case for the patients. We can see the worn occlusal surfaces have been restored with the cast gold adhesive onlays posteriorly, while the maxillary anterior teeth have been restored with indirect resin composite restoration. The placement of this restoration culminated in a very small separation of the second molar teeth. These teeth were allowed to dull concept into occlusion. Category 3, excessive wear without loss of OVD with the insufficient space for restorative materials. These are the most complex cases to manage where no adequate space for restoration is available, while compensatory tooth repositioning is observed. The challenge faced in this situation is to provide space without increasing the occlusal vertical dimension, which is not evident. This is a case where we can see that it looks very complicated and the dental alveolar compensation has taken place. So a variety of strategies have been presented in the literature in order to manage this category. First, surgical procedures like a crown lengthening. Elective endodontics may also be considered, where the application of post and core reconstruction mainly to increase the height of the core and increase thus the retention of the future restoration. Nevertheless, success is partially dependent on the endo treatment. This is a case where we have a limited crown height of the lower anterior teeth. Then we increase the crown height after healing has taken place, a crown lengthening. A less common strategic management for this typically challenging situation is the orthodontic treatment, where we need to do intrusion and extrusion for some teeth. Unless such method failed to provide enough space, an increase in the occlusal vertical dimension would be promoted. It would be assessed through the usage of occlusal splint. So this is a case of a patient who's having tooth wear, which was restored by resin composite with zero tooth reduction. And we can see from the picture that there's a mild attrition that has just started to involve the dentin layer. Intervention advised to prevent further wear, in particular differential wear. So we can see also the post-operative picture after 12 years. So here also another case, the direct application of resin composite to treat the case of tooth wear with the aid of silicone matrix or silicone index derived from a diagnostic wax up. As I said, diagnostic wax up is mandatory, it's very important whenever you have a tooth wear case or rehabilitation. And we can see the diagnostic models, the palatal putty matrix, and the restored teeth with GC composite. This cast gold overlay was used to restore tooth wear on tooth 27 and shows the post view after 24 years with no debones over that period. So you see how much can stay longer. This is also another example of nickel chromium onlay where the patient cannot afford to pay for the gold. So as a conclusion, planning must be based on treatment goals. which are initiated by preventive approaches and finalized by restorative treatment in cases of extensive tooth wear or aesthetic demand. The management of tooth wear cases is by no means always a simple matter. The successful management of a patient presenting with the signs of pathological tooth wear is dependent on the dental operator having a good knowledge and skills, plus the awareness of the principle of occlusion and the available materials and technique for restoring such cases with a high level of predictability and longevity. Where possible, an adhesive additive approach is recommended as the application of conventional restoration may be associated with a high risk of bulbar injury and the copious loss of critical tooth tissue. So in this webinar, we have learned the different types of tooth wear, how to manage it, and how to design the proper treatment plan. Because when it comes to the treatment, it can be done by anyone, but first you need to design the proper treatment plan. And you need to categorize the tooth wear type, which type it will falls in. So that's it for today. Thank you very much for joining our webinar and have a great day. Thank you. Bye bye.